Very good evening. I am Dr. Anita, consultant obstetrician gynecologist at KIMS Cuddles, Guntur. So today our topic of discussion is about the risk stratification in obstetrics. Now, why have we chosen this topic today? All of you are aware that obstetrics is actually a very unique medical specialty wherein two lives are involved, right? So it's both the mother and the baby, and this deterioration can be sudden, it is silent, and most of the times catastrophic. So this adverse perinatal and maternal outcomes are not because that of the lack of knowledge, but it can be that because of lack of this risk assessment, or sometimes because of the checklist. Because how much do we remember in the memory that we've quantified a particular lady as a high risk, and when we don't document it. So risk stratification in obstetrics is a very important point that you all should remember and follow it. Why? Because this process is a systematic thing in identifying, in documenting, and reassessing the maternal and fetal risk at defined points during pregnancy. It has to be during your first antenatal visit, during ongoing pregnancy, during the labor, and the postpartum period using evidence based criteria. Because this transforms the obstetric care from reactive management of complications to proactive prevention and preparedness. So, why does this matter so much? Because we all know that 70 to 80% of the maternal deaths are predictable and preventable. The conditions like preeclampsia, venous thromboembolism, gestational diabetes mellitus, the fetal growth restriction often have early warning markers. Yes, everything comes with a warning signal and a warning sign, and it is up to us how and when we identify this. And how can we do that? When we are prepared, when we are already knowledgeable about it, and when we do this risk stratification. So many high risk women, though, appear clinically stable in the outpatient department, they can deteriorate at any point of time. So documentation of this high risk assessment is now both a medico legal as well as the NABH requirement. So even in spite of this fear of medico legal risk assessment is still implicit but not explicit. So the decisions are often memory based and not checklist based. So reassessment is frequently missed at admission. I mean, though we document some history, some points are often missed out. So when we have this risk assessment tools available with us, it becomes an easier way of doing this risk stratification. So, what are the key principles of obstetric risk stratification? First and foremost, it is structured, it is based on standardized checklists, it is an evidence based, which is aligned with the ACOG, that is the American College of Obstetrics and Gynecology, the Royal College of Obstetrics and Gynecology, the FIGO, the WHO, and our very own FOGSI. So, these particular governing bodies have given certain guidelines and evidence based checklists and tools for us to do this risk stratification. And you have to remember that this risk assessment is a dynamic process. It is not that you just do it at your first booking visit, during the ongoing pregnancy, and it has to happen at each admission and any clinical change. And you have to remember that this is action oriented. Every identified risk must trigger any prevention, surveillance, and an escalation plan. So, why did we say that this has to be a core skill for the postgraduates? Because the first point of contact is the postgraduates, like with the knowledge as an MBBS graduate, or when we first enter into a post graduation. Where are we posted initially? We all start with the antenatal OPDs, right? And then we go for our duties into the labor room. So, this is risk assessment tool is a very important knowledge point for the postgraduates, because the postgraduates are the one who are responsible for the initial assessment and documentation and accountability for recognizing this early deterioration and conveying it to your seniors, escalating it to the consultants, because risk stratification helps the postgraduates to think systematically, not only the postgraduates and to every level, because once you start your post graduation doing it in a standardized strategic way, and it actually lies within you, and it is always there in your memory this way, that even when you go into your practice, you will never miss doing this. And in the first assessment also, when you meet the patient first in your OPD, yes, you the checklist start playing in your mind. And it helps in avoiding the missed red flags. It helps in communicating risk clearly during the handovers, and most importantly protects you medico legally. So this is not as a checklist, but initially when you first a patient approaches you and then you start taking the history, most of the times we have a demographic data with us, so we just document the name, age, and what is the sex, and we just go that way, right? But the most important basic maternal details that we take from the demographic point of view itself are, first and foremost, is the age. What is the risk assessment over here? What is the high risk over there? Age less than 18 years, age more than 35 years, height less than 145 centimeters, it's like a short gravida or a primigravida or a multigravida, then weight is more than 90 kg or the BMI is more than 30. Remember this important thing, because this BMI more than 30 is a very important risk factor in all the risk assessment tools of the GDM, of the preeclampsia risk assessment, the venous thromboembolism risk assessment. So remembering that BMI more than 30 is a risk factor is most important. And then obviously the low socioeconomic status and poor access to antenatal care. Some of them, they are in remote areas or they're not able to access the healthcare units. So identifying this at the first antenatal visit is very important, because if we know, we can educate them, we make them understand that in pregnancy these are the number of visits that are essential. You need to come for this booking visit. After that, when are you supposed to be coming, and how do you plan antenatally? Once you're in your 28 weeks, the frequency of visits is once in 2 weeks. So you understand their access to the healthcare facility, it will be easier for you to educate them, and once they're aware about the particular situation, they make those changes so that they make that healthcare accessible to them. And uh, sometimes it is a late booking, that is more than 12 weeks. I'll let you know why this landmark, that is 12 weeks, is a very, very important, because this missing of having the early booking before 12 weeks is a very, very important point, wherein you can miss the preeclampsia, you can miss the gestational diabetes, and you can miss the other most important point is during this 12 weeks, that is when the placentation starts. So whenever there is a late booking, lot of risk factors are missed at this point of view. Coming to the past obstetric history, so very importantly, it's like most of the times a question based history taking, right? Very few women, even though they're educated and aware, come forward saying this, I've had this in my first pregnancy, or I've had this prior disease, or I've had this, my mother had this particular history, or there has been a family history. Very few women report directly by themselves, rather than when you ask them. So when you come to the past obstetric history, whether was there any previous history of a stillbirth or a neonatal death? Did they have any recurrent pregnancy loss? That again, by the history, you will get to know. As per the governing bodies, the RCOG says it is more than 2, and the ACOG says it is more than 3. And previous history of preeclampsia and eclampsia. Now, this is a major catastrophic event, so they would definitely report about this. Previous history of gestational diabetes. Some of the women are not aware, like, they say, no, my blood sugars have been normal, or I was not screened for this, so I don't know anything about it. So putting a questionnaire to them regarding previous history of GDM is a very, very important to assess their ongoing risk in this particular pregnancy. Previous preterm birth before 37 weeks, previous history of a postpartum hemorrhage, previous operative vaginal delivery, was it a forceps delivery or was it a ventos, previous cesarean section, more than 2 previous cesarean sections, did she have, whether it was a vaginal delivery, what was the weight of that particular baby, did she, if it was a macrosomia, or weights around more than 3.5 kg, was there any history of shoulder dystocia, history of any previous IUGR or fetal growth restriction, then previous macrosomic baby. Now, when you ask them about a growth restriction or macrosomic, it's very difficult for them to say themselves that, there has been a macrosomia or an IUGR. So when you ask them the weight of their previous baby, so basing upon the weight, that when they say whether it was a 2.5, 2.4, 2.1, and then you ask it what gestational age did the baby deliver, then you go back to their previous antenatal history, like, were they told about any of these points, how frequently the screening was done for them, were they told about these complications, and so on. And coming to their medical history, do they have any history of chronic hypertension? Are they already diabetic, overt diabetic, whether they're insulin dependent or they're on any OHs? Do they have any history of hypo or hyperthyroidism, any history of cardiac disease? Like, most of the women, especially when they come with their spouses or when with their mother-in-laws, many of them hide the fact about their history of any congenital heart disease which has been repaired, because of late, because of the advanced interventions, most of them, do not report about a history of ASD repair or a VSD repair, and some of them actually decline, and then later on they come back and they say, no, no, I've had this particular history. So asking this positive history, so when you're talking to the mothers, you just look at them, look at their discomfort, then you can get some idea like, okay, is it, are they giving you the proper history or are missing out anything? Previous history of any renal diseases, history of bronchial asthma. This is a very, very important thing, because some of the drugs have to be avoided during bronchial asthma, during the labor, during management of postpartum hemorrhage, and as well as there can be exacerbations of this bronchial asthma during the pregnancy, during the antenatal period. Previous history of epilepsy or seizure disorder, when was the last episode, are they on medications, did they have a checkup recently with the neurologist, what is the current dose that they are taking, and do we need any further multidisciplinary consultation regarding this, do they need to meet the neurologist again, do we need to increase that particular dose? And most importantly, with the advent and increase in the risks, or the occurrence of this autoimmune diseases, like nowadays if we see, many of them are having this autoimmune diseases like SLE, the Apla syndrome, and most of them, when you are, screen them or have any history of recurrent abortions or recurrent pregnancy failures, when we evaluate them, we are seeing a lot of them to be ANA positive also. So identification of this autoimmune disease at their first booking is very, very important. Then thrombophilias, like, these are the hereditary diseases, history of any thrombophilias that they have, like protein C, protein S deficiency, antithrombin 3 deficiency, hyperhomocysteinemias. Of late, we are facing a lot of challenges like this because women are having this history. And again, at the booking visit, or sometimes they do say that I have had anemia previously, or I used to have heavy bleeding, so my HB levels, my blood levels were low. So anemia, hemoglobin less than 10 grams. And then once you assess the medical history, you go to the surgical history. Then you ask them any history of uterine surgeries. This is very, very important. Again, some of them miss giving this history, whether they've had myomectomies or any septal resections, because it is very important. You understand the mode of delivery. You counsel them regarding what is their mode of delivery at the beginning. If she's had a myomectomy, what type of myomectomy was done? Was it a subserosal fibroid? Was a cavity entered? So you discuss that she would have to be delivered by a cesarean section. So this understanding of their risk factors and creating an awareness for them and making a checklist for yourself and how to plan the ongoing antenatal checkup as well as planning for the delivery is very, very important. And then did they have any cervical surgeries like a leap procedure or a cone biopsy, because again they can have history of cervical incompetence. So assessing this at the first booking visit is very important. And history of any uterine anomaly, any fibroids. Now, of late we are seeing some of them do present at their first early antenatal scan. You see that there is a fibroid complicating pregnancy. Sometimes it's 3 centimeters, sometimes there is a large fibroid. So whether they've had a history of any, fibroids distorting the uterine cavity, and any history of endometriosis which has been severe. Okay, now coming to the current pregnancy, what are the antenatal risk factors in the current pregnancy? Has it been, is it a multiple pregnancy? Is it an ART pregnancy, that is assisted reproductive pregnancy? Is it an IVF or an ICSI? Is it an RH negative pregnancy? Again, some of them know their blood groups nowadays, but some of them do not know. At the first booking visit, we do their labs, and when we identify the blood group, we checklist over there, put it as an RH negative pregnancy. Educate the mother again about the importance of maintaining the hemoglobin levels, as well as being ready with donors at the time of delivery, because there's nothing like a low risk pregnancy nowadays. So you can anticipate a postpartum hemorrhage anytime, either it is a normal delivery or a C-section. So at that point of time, availability of donors, sometimes it can be O negative. The blood banks might not have it. So, by educating them right from the first visit itself, they will arrange for donors during the time of delivery. And any pregnancy associated with a medical disorder actually is a high risk pregnancy, and the in the current pregnancy, presence of a placenta previa or a low-lying placenta, and if it is a previous cesarean section or a placenta accreta spectrum has been suspected, any abnormal lie or presentation. It can be a breech presentation, it can be a transverse lie, then presence of polyhydramnias, oligohydramnias, the fetal growth restrictions, any history of congenital fetal anomaly. Okay, so coming to the family history. Now, when it is the family history, what do we see? Family history, most of them when we ask history of hypertension, history of diabetes, multiple pregnancy, congenital anomalies, and a congenital heart disease. This is very important because basing upon this, you make an assessment of when to get the TIFA done. Now we have an early TIFA and a late TIFA. So basing upon their history of in the previous pregnancy, or if there are primigravida in their family, if any one of them has this history of congenital anomaly and more so importantly a congenital heart disease, even though the TIFA says that the heart has been normal, always going for a fetal echo between 24 to 26 weeks is important. So when you identify these risk factors at the booking visit itself, you make a plan for yourself. Okay, this is because sometimes you're busy in the OPD, you've just come down from a surgery, or you're about to go when the mother is somewhere in full dilatation or something, and then that point of time, that visit, this is missed. But when it is marked in the plan that yes, there is a plan for a fetal echo for this lady in spite of her TIFA being normal, right? So identifying each and every history in the mother is very, very important. And the most neglected, or sometimes you just tend to miss this, are the environment and the lifestyle factors. Okay, history of any substance abuse, any history of alcoholism, history of any psychiatric disease, how is the mental status of the mother, and sometimes there is history of domestic abuse, which some of them do not report, some of them, that is through during their antenatal visits. History eliciting is very, very important. So identifying these risk factors at the first booking visit is important. Now we are aware during our MBBS period and in the even in the post graduation, we just start making writing the history in our antenatal cards, and sometimes it is not documented, and then you write past history nil significant, family history nil significant, right? And then what happens, sometimes you just tend to forget or miss these points. But if you have a checklist or an algorithm based approach like this, wherein you have risk assessment tools, so it is clearly marked over there, and then after you do the entire risk assessment, you mark it as a low risk, a moderate risk, or a high risk. So when you have this particular sheets in your ANC card, it becomes very easy because you make a management plan right within the first visit itself, right? So you do initially no risk factors identified, you put it as a routine antenatal care. You identify any major risk factors like she's had a previous history of severe preeclampsia, or any history of VTE, or any other issue when the mother has had a history, and a current pregnancy you've identified that it's a multiple pregnancy. So you check, tick the checkbox of increased surveillance over there. Or sometimes it needs a specialist referral, like we have talked about epilepsy, we've talked about a bronchial asthma, we've talked about a history of heart disease prior. So all this, in those cases, you need to go with a specialist referral. And then multidisciplinary care, right? Okay, this particular lady requires a multidisciplinary care, and what is the plan for delivery? What is the mode of delivery? And this risk assessment over here is not only at the first antenatal visit itself. Then it is, as I have told prior, that it is a dynamic process. So once you check again at each trimester, okay, this has been a routine antenatal care, and as the pregnancy advances, you identify any ongoing, emerging risk. So again, you recategorize, you do the reassessment, and then you make a plan again. So the first visit itself doesn't mean that it is a routine antenatal care there, because pregnancy is a dynamic thing. There are a lot of physiological changes happening. There are a lot of current risk, emerging risks happening. So this has to be reassessed at every trimester, at every admission, and then even during labor. So, what I would recommend is you generally have a checklist like this. So, most of the times when it's the first early booking, when the mother is coming to you in the first visit, so you have a first trimester checklist wherein the patient identification data is here. So, therein you put the dating of the pregnancy. Is it the expected date of delivery is verified either by the LMP or by the first trimester scan, or you have come to the a diagnosis or a conclusion of the corrected expected date of delivery when basing on the LMP as well as the first trimester scan, whether it's a good dates or bad dates, and then you have considered it through the first trimester scan, through the 11th to 12th week, 13th week scan, and then screening for preeclampsia at the first visit itself. Again, first is with the history based screening that is done, whether basing upon your risk assessment, low dose aspirin indication has been assessed or not, and whether she needs it. And most importantly, the first trimester combined screening has been offered or not. If it has been offered, you tick the checkbox over there, and the mother has refused it, you can actually mention that this has been refused, and then you counsel them again regarding it. And the most important risk assessment tool for prediction of preeclampsia and helping in prevention of a preeclampsia, to look for any small for gestational age, fetal growth restriction, this papa values, pregnancy associated plasma protein, which is a very very important, the multiples of medium, the mom less than 0.42 actually poses a risk factor for prediction, and any intervention when you identify this, when you start the low dose aspirin, can prevent development of preeclampsia, or it can reduce the severity of the preeclampsia, or it can happen at a later gestational age. I mean, instead of early onset of severe preeclampsia or occurrence of an eclampsia, this will prevent the complications associated with the preeclampsia as well. So, the most important component of the first trimester risk assessment is the history of a previous pregnancy or history in the family, the first trimester combined screening, wherein you look for the papa values, the multiples of median of the papa values, uterine artery Doppler, the map, are very very important risk assessment tools in prediction, prevention of preeclampsia and fetal growth restriction. Then the other thing, most importantly, that has to be done during the first trimester is the genetic screening. So this genetic screening has been offered or not. So what do you do in this genetic screening is, once when you evaluate the NT scan, you look in for the markers, you look in for a double marker, and if required, basing on it, the Western countries go in for an NIPT for most of the cases, but in our country, basing upon the risk assessment that we have identified, so we go in with this go in with the double marker, and then the risk category is being explained, evaluated, whether it is a high risk or a low risk. Does the family have a history of Down syndrome or any other chromosomal disorders, or you identify any risks pointing towards this aneuploidies like Down syndrome, or any ultrasound markers, the soft markers suggestive of it, the NT value, the papa values, the risk assessment that comes with the double first trimester screening, whether it poses, and basing upon this, does an invasive testing need to be offered. So the first trimester risk assessment about these 2 points, that is why I have pointed out in the first history taking, is late booking beyond 12 weeks, because it is in the first 12 weeks wherein you can identify this particular factors, because you can't do a first trimester screening, the double marker, if it is crossed beyond 13 weeks 6 days, and you cannot identify the risk factors associated. Because when you identify something, you start when you have these values which are done at that early booking, you can add in the low dose aspirin, because the important time to start this low dose aspirin is between the 13th to 16th week, wherein uh, the prevention and the prediction of preeclampsia is more better at that point of time, because that is when the placentation happens. And basing upon the history, the risk categorization about diabetes, any preterm labor, previous history of SGA or fetal growth restriction, history of a stillbirth, postpartum hemorrhage, and history of a venous thrombus embolism. And at the first booking itself, you look in for the antenatal laboratory test, most importantly the blood grouping and typing, to identify any RH negative pregnancy, a complete blood picture. So through this complete blood picture, you get to identify through this complete blood picture, you get to identify the what is the hemoglobin level, what is the WBC counts at that point of time, the platelets, because at the first booking you understand in pregnancy there can be gestational thrombocytopenia. So ongoing pregnancy, sometimes marking somebody as that, so you have to have a baseline level of what her platelet count has been, of what her baseline hemoglobin has been, because as you know, the fetus takes the requirement increases trimester wise from 4 grams, 6 grams to 8 grams. So the baseline hemoglobin is very, very important. Then what has been a complete urine examination, because asymptomatic bacteriuria is very common in pregnancy, and identifying it, then going for a urine culture sensitivity is very, very important. And the baseline TSH levels, the VDRL testing, the screening for the viral markers like the HIV, the hepatitis B, and the HCV. And because now we are seeing a lot of issues with the hemoglobinopathy, so HB electrophoresis and a baseline HbA1c and the fasting blood sugar, and any history of a multiple pregnancy, sorry, any history of a multiple pregnancy, whether it has been a singleton pregnancy or twins, and if twins, what is the chorionicity? Because again, the chorionicity is identified in the early trimester itself. Basing on the chorionicity, you again need to counsel the patient regarding the risk factors about how the pregnancy, ongoing pregnancy, the risk of congenital anomalies, and how do we plan the mode of delivery. So chorionicity is again a very, very important thing to identify in multiple gestation, and documenting it is important, whether it is a DCDA, MCDA, and MA is a very, very critical. So counseling and conveying this to the patients is very important at that point of time. Okay, and then whether the uterine artery Doppler has been done along with the NT to put the risk assessment for the hypertension. So when you have an antenatal risk assessment, instead of having pages and pages or you documenting, writing everything, and how our handwriting is, sometimes it is not legible, sometimes it is too fast, too quick, difficult to understand. So it is always better to have an A4 sheets of these, wherein you can attach it to your antenatal card. You can have along with your initial assessment, you can have a gestosis scoring, the prediction and prevention of preeclampsia. You can have the VTE checklist. You can have the gestation diabetes mellitus checklist. You can have the fetal growth restriction risk assessment. And basing upon this, you can and finally put a risk category, whether this is a high risk, low risk, or a moderate risk, and what is your plan of escalation, what is your mode of delivery, basing upon that. And once you attach this, and again the fifth checklist has to be at the time of admission, wherein all these checklists are re-evaluated, and basing upon that you have an admission criteria. And then ongoing care is also a very, very important at any clinical change, like suddenly the blood pressures have shot up, so again you do a re-assessment, and any new risk has emerged, and documenting and reassigning the risk is also a dynamic event. And once this has been completed, the checklist and who has done it, because it is easier for your handovers also this way. This is just, we'll go in detail with each and every checklist. The first and foremost is the maternal and obstetric history that we were talking about. Then we should have a checklist for the gestosis and the preeclampsia risk. We should have a VTE risk. Then we should have a GDM risk assessment tool. We should have for fetal and pregnancy other associated risk, and communication or any current risk that has emerged during this pregnancy is also important. So let us come to the individual checklist that we have talked about so much till now. So first and foremost, we will most commonly or most easily preventable or most easily occurring risk is the gestational hypertension, the preeclampsia, the severe preeclampsia. Now the hypertensive disorders of pregnancy has been reclassified and separate definitions have been given. So for prediction of preeclampsia, universal screening is recommended, but there is no single effective screening test. One particular screening test cannot say that this there is a risk of preeclampsia. So it is an amalgamation of the history of the mother, and in the history also there are the maternal history, the family history, history of current pregnancy risks, and adding all those things to a particular risk assessment test, we come to a risk scoring in preeclampsia. And none of the tests proposed till date predict the at-risk population for preeclampsia. So we generally cannot recommend one particular test for general population screening. So the assessment of clinical risk factors has to be very, very vigilant because it helps us in prediction of this preeclampsia. A careful history taken early in the first trimester can warrant an attention for the effective prediction and prevention towards the mothers at risk at a very early stage. Now, sometimes we do see some women come at 26 weeks, some of them land in eclampsia, some of them come in with severe preeclampsia. Recently, we've had a case, a lady who came to us at 26 weeks, a primigravida. She says there has been no risk, and then suddenly she's developed full blown hypertension, severe preeclampsia. And then one more lady was referred to us at 34 weeks with an intrauterine fetal death. And what they say is because this lady had a previous history of polycystic ovarian syndrome and she never had any regular cycles. So she did not know that she was pregnant till the fifth month of pregnancy when she started to notice some fetal movements, because she's been getting her cycles once in 3 months, 4 months, or she's been only having a withdrawal rate. So she never realized that she was pregnant. And what has happened at fifth month when she went, a TIFA was done, and there was no proper, I mean, from her part, it is not from the obstetrician point of view. She's been going to different hospitals at different antenatal visits. And finally, she landed up with severe preeclampsia, HELP syndrome, and it went into, and it actually led to a abruptio placenta, and she was referred to as in a very, very critical phase. So risk assessment at the first antenatal visit is a very, very important aspect. And this risk assessment tool has been given to us by the hypertensive disorders of pregnancy, the gestosis scoring. This is given by our very own Foxy GCPR guidelines. GCPR is a good practice guidelines. This is available freely on the net. So this hypertensive disorders of pregnancy gestosis score is a process of risk scoring. This score involves all the existing and emerging risk factors in the pregnant woman. So each score, each risk has been given a score of 1, or basing upon the risk score of 2, or if it is a very high risk factor, a score of 3 is allotted to each clinical risk factor as per its severity in the development of preeclampsia. Now, with careful history and assessment of a woman, a total score is finally obtained time to time. Now, when the score is more than or equal to 3, the woman should be marked as at risk for preeclampsia. Now, when somebody comes with a score of 2 or 1, and then what you need to identify is any current emerging risks that are coming, and then you need to reassess and reevaluate the risk again. So as we always speak, the first and foremost is the age beyond 35 years, that is the extremes of age groups, beyond 35 years or less than 19 years of age, and history of maternal anemia. I've constantly been telling you about this obesity, that is BMI of more than 30. Then a primigravida is always, you feel that she can be at risk, so we've given a score of 1. And then short duration of sperm exposure, that is she's conceived immediately after marriage when because of the cohabitation. And when women herself is a small for gestational age, there has been a family history of any cardiac disease. She's had a history of polycystic ovarian syndrome, this particular case that I was talking about. Then the interpregnancy interval is more than 7 years. Then she has conceived with assisted reproductive techniques, like she's had a IVF or an ICSI pregnancy where the mean arterial pressure is more than 85 millimeter of mercury. So it is not just one reading that you take when the lady comes to you. So it has to be a mean arterial pressure of more than 85 millimeters of mercury, again is given as a score of 1. Then Any history of chronic vascular disease, dyslipidemia, again is given a score of 1. Then she's had had excessive weight gain during that particular pregnancy. Then the maternal hypothyroidism, family history of preeclampsia. She's had a history of gestational diabetes, obesity, that is more than the BMI here. When we are coming to the score of 2, whether the maternal hypothyroidism is given a score of 2, a family history of preeclampsia, when you ask, when you dig back retrospectively, you see that the mother also says that yes, she vaguely remembers that her doctor has told her that she had hypertension when it is a milder case, or sometimes it is my mother had hypertension during her pregnancy. And then history of gestational diabetes, obesity more than 30 is risk factor 1 and more than 35 is risk factor 2. Then this is um, any history of hyperemesis during the previous pregnancy. Then pregestational diabetes mellitus is given a score of 3. Chronic hypertension is given a score of 3. Then any medical disorders, a score of 3. Then history of inherited or acquired thrombophilia is a score of 3. Then maternal chronic kidney disease, autoimmune factors like SLE, APLA, rheumatoid arthritis, and any pregnancy with an assisted reproductive treatment, whether it is a surrogacy or a oocyte donor, gets a score of 3 in Gestosis scoring for prediction of preeclampsia. Okay, so when you see a BMI of 30 is 1 and a BMI of more than 35 comes to a score of 2. And assisted reproductive techniques with an IVF ICSI comes with a score of 1, and here an OD or a surrogacy comes with a score of 3. So in those cases, the use of low dose aspirin is very, very important. Uh, so you can have a checklist like this, or you can have that particular risk history. You know, when you take a printout of that and attach it to your antenatal card, you can just tick the tick boxes, and you calculate the risk, and then you just put it over there, and with bold letters marked in red or something, when it's easier to catch, because you might not be seeing the next antenatal visit in the medical colleges, right? So it goes to some other, you are not available, you are in your labor room posting, or the consultant changes or something like that. So it's always better to add to that risk assessment and keep a checklist like that. Okay, now or a simpler way is the pre-eclampsia assessment risk. You can have a simpler checkbox like what's the gestation age, when you have identified, started plotting this risk assessment, previous high risk factors, any one of the high risk factors, a previous preeclampsia, but always go with the Gestosis scoring. That is a standardized thing. But to remember, the high risk factors are a previous preeclampsia, eclampsia, the chronic hypertension, the diabetes mellitus, whether it is that is the overt diabetes mellitus, history of a renal disease, autoimmune diseases, multiple pregnancies. These all come under high risk for development of preeclampsia. And then any moderate risk factors like any two will again become high risk. Okay, one moderate risk factor, but two moderate risk factors will again become high risk. That is again a primi gravida, age more than 35, BMI more than 30, family history of preeclampsia, interpregnancy interval of more than 7 years, assisted reproductive treatment like IVF ICSI. So you categorize low risk or high risk. As per the Gestosis scoring, anything which comes up to 3 or more than 3, you start with the low dose aspirin. Now, low dose aspirin, again, there is a debate between 75 to 150. The current guidelines say it is better to give 150 in the evening time to prevent this preeclampsia. Okay, now let us come to this GDM, or the gestational diabetes risk assessment. Now, this has been given by the American Diabetic Association, the NICE guidelines from the Royal College of Obstetrics and Gynecology, the Foxy Dipsy, that has the Foxy Dipsy guidelines have actually mentioned that any woman who comes to her first booking visit with these high risk factors, like previous history of a gestational diabetes, obesity, again a BMI of more than actually 30, but in Asians we have put the cutoff as more than equal to 27.5, a family history of type 2 diabetes, history of a polycystic ovarian syndrome, because that these women have insulin resistance, any history of acanthosis nigricans, like when you first observe the patient, you can see the dark marks over the neck, the pigmentation over the neck, or you can actually ask them this history when you see they're obese. And most importantly, the macrosomia in previous pregnancy. So most of them say, no, I don't have GDM, I didn't have any diabetes during my pregnancy, but my baby's weight was 4 kg, or it was 3.7, 3.8. So even when they say that they do not have a history of gestational diabetes mellitus in their previous pregnancy, the weight of the baby in their previous pregnancy, you have to actually mention it over there, and remember, basing upon that, the ongoing assessment and evaluation is very important for this GDM. Then what are the moderate risk factors? Again, nowadays we are having women planning for pregnancies at a later age. So 30, 35 is that particular age group has become very common nowadays. So any age beyond 30 is a moderate risk factor for development of gestational diabetes in pregnancy. Then a sedentary lifestyle, central obesity, any first degree relative with a metabolic syndrome. So low risk are a normal BMI, no family history, and presently no current your evaluation and testing has shown that there is no history that suggestive of or risk suggestive of her developing any GDM. Now, why is this important? Because when you identify a particular risk factor of gestational diabetes mellitus, when you identify this particular event, about that history, how do you screen for GDM? And what is the assessment? What is the test that you have to offer them when you identify any risk factor? So the Foxy Dipsy has given us certain guidelines of when to test, how to test, and what particular test has to be done. So when you identify it as a high risk for development of gestational diabetes mellitus, so at the first booking visit, if you have she's had a previous history, or her blood sugar, her fasting blood sugar level is high, or her HbA1c is high, then you offer a oral glucose tolerance test at the first booking visit itself. If that is negative, you do the reassessment again between 24 to 26 weeks. Or if the fasting blood sugars or the HbA1c are normal, but this woman has had a previous history of gestational diabetes, you go with the OGTT at the first booking visit itself. Okay, and then you repeat. Suppose if it is positive, if the OGTT says that it is there is, I mean, she is gestational diabetes or an overt diabetic at that point of time in this first booking visit itself, then continuous monitoring of blood glucose. You have to make her aware. You have to educate her like how to do the monitoring of blood glucose at home, the diet modifications, the activity levels, and how to report what are the baseline blood sugar values that she needs to she has to stay with, right? So when you identify this that it is negative, then you do repeat the testing again between 24 to 26 weeks of gestation, and even then the test is negative, you just put her in the routine screening. But your clinical assessment, when you're doing your antenatal visit, you're doing your obstetric grips, and you identify that the liker is slightly on the higher side, or the symphysiofundal height is more than the period of gestation, then you have a clinical suspicion and you get an ultrasound done, and then you see a polyhydramnios, so you put the growth curves and you see that it is going on to the macrosomia picture. That's when again you do reassessment, you check for the blood sugars again and put the mother, because again this is a dynamic event. The risk can emerge at any point of time, because as Asians of Indian ethnicity, origin of Indian ethnicity, we are all prone for this gestational diabetes, because we have that risk of insulin resistance in us, in our ethnicity itself. Okay, so this assessment is very, very important at every gestational and at every trimester, and monitoring and putting a plan for delivery. And how do you monitor this even during labor? Like if it is a normal delivery or a C-section, how do you monitor? How do you plan is also a very, very important assessment. And at this time, you even need to educate them on how to get this GTT done. What is the preparation for this GTT done. Because when you say you have to go for a GTT, then women, they do not eat anything the previous 2 days, or how it is done, how much glucose has to be taken, in how much amount of water has to be, it should be mixed with. So you have to have a sound knowledge of just not prescribing like get a GTT done or get a GCT done. You have to have a sound knowledge of how this test has to be done, so as to educate the women, because and how they are doing, which labs they are doing, because interpretation of the values is very important. More than interpretation, how this particular test has been done is also important. And nowadays, even though the most of the time you identify that it is a GDM. So what do? They go with their fasting postprandial levels, and then like it has been normal. But most importantly, rather than GDM, nowadays it is hyperglycemia of pregnancy. The DIPSI guidelines have coined this term, the GDM, as hyperglycemia of pregnancy. So it is not only the fasting postprandial levels, the elevated levels which are suggestive of a GDM, but sometimes a pre-meal, that is, it can be a pre-lunch, post-lunch, or a pre-dinner, post-dinner high blood sugars also lead to the adverse outcomes that we observe in a GDM. So home blood sugar monitoring has to be educated to the mother and their family. So coming to the, just a second. So now we're going to see about this uh, risk assessment or screening for early onset of fetal growth restriction, how to do the triage. Okay, now first and foremost, when we see the triaging has been done as green, yellow, and red, and when we come to this low risk group, wherein there are no risk factors, so you go with a routine anomaly scan, and when the estimated fetal weight is more than equal to 10th centile, that lady goes in for the screening surveillance pathway. When you see is serial measurement of symphysiofundal height, that is, you check with your measuring tape from the symphysis pubis to the fundal height, and as per the dating, whether it is appropriate, whether the symphysiofundal height is appropriate for that particular gestational age, and everything has been going normal, you reassess at 28 weeks and after any antenatal admission. Now coming to the moderate risk. Okay, now when you're coming to the moderate risk factors, first and foremost are the obstetric risk factors. And in any obstetric risk factor, the most important thing is any previous history of a small, for gestational age, previous stillbirth, previous AGA, the birth weight is very less. And coming to the current risk factors, so the current risk factors can be history of any smoking, drug abuse, yes, in the Western population, but more so now, even in India, we are facing these particular risks. And the women age beyond 40 years at booking, or the BMI is actually less than 18.5, and other features of like eating disorders, bowel disorders, like an inflammatory bowel disease causing the weight loss. Any history of, now a lot of women are undergoing this bariatric surgeries, so any history of gastric bypass surgery or a bariatric surgery, then a sleeve gastrectomy has been done, previous history of tuberculosis, a second trimester miscarriage, previous history of preterm birth, and any placental mediated event has happened, these come as a moderate risk factor. So what do we do here? We assess for history of any placental dysfunction and consider prescribing aspirin for all women on moderate risk pathway, and require a symphysiofundal height as measurement from 28 to 40. The current guideline says that this symphysiofundal height measurement has to start from 24 weeks onwards. And then you do an anomaly scan, and when the estimated fetal weight is more than 10 centile, you do serial ultrasound assessment from 32 weeks every 4 weeks until delivery. And then you assess for any complications developing in the pregnancy, like any history of hypertensive disorders or any significant bleeding you have identified. Now coming to the red flags, that is the high risk factors. Now the high risk is medical history, whether the mother has any maternal conditions, chronic kidney disease, history of hypertension, autoimmune disease, any complex cardiac disease, Coming to the obstetric history, previous history of fetal growth restriction, hypertensive disorders in previous pregnancy, previous small for gestational age or a stillbirth, and in the current pregnancy where the papa values are less than fifth centile, just remember blindly any papa value less than 0.42. Okay, so the RCOG says less than 0.42, the Fetal Medicine Foundation says anything less than 5, but remember the value of 0. Less than 0.42 moms, you have to be very cautious in that pregnancy. And inhibin A levels. Now, when we come to the markers, most commonly useful thing is the PAPA. The other additional things are the in prediction of SGA or FGR is the inhibin A values when the second trimester, that is more than 2 multiples of median. Then the alpha fetoprotein level more than 2 moms, that is in the second trimester when you go for a quad testing there. Then the echogenic bowel. Yes, some we do see now in the TIFA scans, like everything is being normal, but there is an echogenic bowel. So we do report that yes, we will follow up with an echogenic bowel. It is one of a soft marker. We have ruled out the aneuploidies, we have ruled out the chromosomal abnormalities, but what risk are we facing? The risk of a growth restriction. Okay, so we need to be cautious when we see this report in the ultrasound suggestive of an echogenic bowel. And history of any significant bleeding, like she's had a large subchorionic hemorrhage in the first trimester, there is a small retroplacental clot, because nowadays we're seeing some of the ART pregnancies and some of pregnancies are complicated with this. So when there has been a significant bleeding, when there has been a subchorionic collection, there can be chances of this SGA, and that pregnancy has to be monitored very closely for this SGA and FGR. And most importantly, a single umbilical artery. Single umbilical artery, again, the weights of the baby can be less, it can be SGA, and it can actually progress to a fetal growth restriction. And the other risk factors are like the woman unsuitable for monitoring of growth by the symphysis fundal height. Okay, we'll come to that later. Now, when we identify this high risk factors, we have to consider prescribing the aspirin of 150 milligrams at less than 16 weeks of gestational age as appropriate, like previous history of hypertensive disease, previous FGR, less than third centile or less than 10th centile, or any baby that has been born before 34 weeks. And here warrants the evaluation with a uterine artery Doppler. If the uterine artery Doppler is normal, you go with an estimated fetal weight more than 10th centile. You go for a serial ultrasound assessment from 32 weeks onwards, every 2 to 4 weeks until delivery. If the normal uterine artery Doppler and this is less than 10th centile, previously it was more than 10th centile, less than. Here you have to start the serial assessment of the ultrasound right from 26 to 28 weeks until delivery. And when there is an abnormal uterine artery Doppler, that is, there is increased PI or there is an increased placental resistance that we have observed, but the estimated fetal weight is more than 10th centile, you do the serial ultrasound assessments from the 28 weeks onwards, here every 2 to 4 weeks until delivery. And then once this abnormal uterine artery Doppler or the AC or the estimated fetal weight is less than 10th centile, you discuss with the fetal medicine consultant, you do a multidisciplinary, you do a proper thorough counseling, okay, and you follow up this patient serially until delivery. And then any interventions that have to be taken, like you feel, no, this is not going to progress, we're going to get some Doppler abnormality, any umbilical artery abnormality, there is an increased resistance, there is an absent, it can lead to an absent or it can lead to a reversal. So that is when we need to take any active decision to deliver the baby. So during this ongoing screening, to improve the fetal lung maturity, you give the antenatal steroids, and you feel there is a definitive need to deliver for any neuroprotection, admitting the patient for a magnesium sulfate regimen. And then so risk assessment is an ongoing screening process wherein you identify that particular risk and go ahead. So, and most importantly, nowadays, when we are doing the assessments or when you're doing the checkup, you just put your hand, you look for the umbilical, the height, where is the fundus of the height. You just mention as 16 weeks, 18 weeks. No. But instead of doing that, this estimation of symphysiofundal height is a very, very important tool or a skill from your side to identify, because it is going to help you in identifying the appropriate gestational age, and does it match with your LMP EDD or with whatever EDD that you have assigned at your booking visit. And along with that, it helps you identify whether the liquor has been less, or whether the growth of the baby seems to be less, or whether it is an macrosomic baby. So these are very, very important tools, the Symphysio. So I urge all the postgraduates, because even till today, I always have a measuring tape with me in my OPD and even in my handbag. So I do the Symphysio fundal height assessment thoroughly. So, but who are the women who are not or unsuitable for this monitoring by the Symphysio fundal height measurement? One is obese ladies, yes, because naturally their body fat, the thickness of the abdominal wall is more. So in those cases, your Symphysio fundal height is not accurate. I mean, it cannot predict the appropriate gestation age basing upon the clinical estimation or history. Nowadays, as we've seen, the increased emergence of fibroids complicating pregnancy, any congenital uterine anomalies, there can be an arcuate uterus, there can be a septate uterus, and polyhydramnias again. So in those cases, multiple pregnancies, there is no role of using this Symphysio height. I mean, those mothers are unsuitable for this. And in such cases, you have to do an anomaly scan and an estimated fetal weight of more than 10 centile. So in cases wherein this clinical assessment using your Symphysio height is difficult, so you do the serial ultrasound assessment right from 28 weeks onwards, uh, and especially in those with a congenital uterine anomaly, and 32 weeks you reassess, because in this after this particular gestational age, it is difficult to assess with the Symphysio height. Okay, so coming to the next is this antenatal assessment and management of the VTE. Right now, most of the times, this risk assessment for venous thromboembolism is missed most of the times. Like as a postgraduate, I was not taught about this, but off late that I'm seeing so many risks of this VTE. Nobody comes and says that I've had a blood clot in my legs. Very few women do complain, but nowadays I'm seeing a lot of women who've had, I mean, recently in my OPD, now she's I think 28 weeks, who has come with a history of internal jugular vein thrombosis, and on evaluation she was identified to have a protein S deficiency. Now her first booking visit with me was at 28 weeks, and I was so surprised to see that there was no use or no documentation of this particular history. And the woman is telling herself somewhere in one corner in the first booking visit, a small note has been mentioned, like history of internal jugular vein thrombosis, history of protein S deficiency, and that's it. There was no further assessment and no further intervention done for her. Ideally, this candidate has to receive a thromboprophylaxis with low molecular weight heparin. One is to prevent the recurrent attack of a VTE. The second is she is a risk factor for preeclampsia. She is a risk factor for SGA. So she could have had an adverse event, in whichever way. So any previous history of VTE except a single event related to a major surgery. Now here again we have a high risk, intermediate risk, and low risk. So in the high risk, remember, all the high risk women require antenatal prophylaxis with low molecular weight heparin. Okay, now in the hospital admission, when you're doing it, so a single previous VTE related to a major surgery, the very, very high risk, like sometimes, most of the times when you've had a major surgery, you do have immobilization. So that is a triggering factor for a VTE. So that is not put as a high risk factor for a VTE, but that is put as a intermediate risk for a VTE. Any high risk thrombophilias but did not have a VTE. Okay, they have been during evaluation either for a recurrent pregnancy loss or something, but they have not been evaluated for a VTE. So those cases come again under intermediate risk. Any medical comorbidities like history of any malignancy, heart failures, active SLE, inflammatory bowel disease, and inflammatory polyarthropathies, nephrotic syndrome. Nowadays, this nephrotic syndrome has also become a very common commonly, risk factor. I mean, because I work in a high risk unit, we have a lot of patients who've been referred to us with history of this nephrotic syndrome. And I have seen one patient who's come to the OPD at 24 weeks. She's been booked with us at 24 weeks, 24 to 25 weeks, and then the blood pressure in the morning checkup was normal. Suddenly she lands up into the ER with an eclampsia, and then on evaluation we identified she has a chronic kidney disease. When a biopsy was done, she did have a nephrotic syndrome. Okay, so history of a type 1 diabetes, uh, any surgical procedure like in any appendectomy, and most importantly nowadays, since we have ART pregnancies, any history of ovarian hyperstimulation, which is in the first trimester itself. So this comes under intermediate risk, and here we have to consider antenatal prophylaxis with the low molecular weight heparin. Now again, basing upon the scoring, I'll tell you when is what gestational age we have to start this low molecular weight heparin, and how to continue this low molecular weight heparin. Okay, now these are risk factors wherein we give a scoring of 1, like obesity, the BMI of more than 30, again age. So if you observe, these are all the important things that you need to remember, because this in the all most of the risk assessment tools, the obesity more than 30, the age more than 35, parity more than 3, a history of smoking, has gross varicose veins. Again, this can become even more during pregnancy because of lot of physiological changes that are happening with the weight of the growing uterus. Then history of current preeclampsia, immobility, family history of any unprovoked or estrogen provoked VT. Now, of late, we are seeing a lot of estrogen and even progesterone provoked, because we are having a lot of AUBs. We're seeing a lot of AUBs, and good cycle control comes with norethisterone. But sadly, we are seeing a lot of cases. I have seen a case with the CSVT post norethisterone use. I have seen a case having hemiplegia post, had a stroke, had a blood clot, and then had a hemiplegia following the use of a progesterone, norethisterone. So I think it is better we shift for this medroxyprogesterone rather than this norethisterone to prevent this VTE risks. And history of low risk thrombophilias, history of multiple pregnancy, and it is an IVF for an ART pregnancy. So when you identify this, so 4 or more risk factors, the low risk category wherein you give a scoring of 1, 4 or more risk factors, they have a prophylaxis from first trimester, and any 3 risk factors from 28 weeks onwards. Okay, so this high risk you definitely continue right from the booking visit, and here the intermediate also you consider. But these single risk factors wherein you give a score of 1, in these cases, if it is 3, you start from 28 weeks. If it is 4 or more, you start with the first trimester itself. And if anybody has had fewer than 3 risk factors, so these come under low risk, and here mobilization and avoidance of dehydration. But always remember, if you think it as low risk or anybody in pregnancy, always advise for mobilization and proper hydration, because pregnancy itself is a thrombogenic state. So from the first booking visit itself, like when you ask, a lot of mothers keep questioning us like the type of diet, hydration, nutrition, and all those things. But most importantly, they always think about what to eat, but they forget about hydration, which is a very, very important aspect. Right. So what I have told actually previously. So again, this is a red flag wherein you give a score of 4 for the very high risk, that is previous VTE, except which is not related to a major surgery. Then a score of 3 for a previous VTE by major surgery, a known high risk thrombophilia, medical comorbidities that we have already dealt with. So all these things will get a score of 3. And coming to the AMBER, family history, here you get a score of 1. Okay, what all things that we have already dealt with. And coming to cesarean section in labor, right? So you remember this gets a score of 2. So even though you know about this, sometimes it's very difficult to memorize, and in the busy time you have, you have a lot of patients waiting outside, you can't just keep remembering, yes, what, then what, then what. So when you have this risk assessment tools attached to your ANC card, you just tick the checklist, and then yes, you put a score and mark it in the red, and then yes, that is done over there. And then at every visit you just go back, go through the files. Suppose you don't do this, you write it at some point, can be a risk factor, and the lady comes with a huge bundle, and then going back and referring back becomes very difficult actually. So the points to be noted, why in spite of explaining to you everything over there, I have put the scoring marked in the red, in the orange, and the amber. Here are the intermediate risk factors, the scoring which get a score of 1, but in those also, previous cesarean section we give a score of 1, but a previous cesarean section in labor gets a score of 2. And sometimes there are transient risk factors like any surgical procedures in pregnancy. Nowadays we are seeing torsion of ovary, they have been operated, or you have done, sometimes some of them needed a cholecystectomy, sometimes an appendectomy, or during the puerperal period, except any immediate repair of the third degree perineal tear or any postpartum sterilization. Okay, then hyperemesis gravidarum also poses, because what happens there? Major dehydration, and dehydration is a major cause for development of a VTE. And OHSS, that is ovarian hyperstimulation, in the first trimester itself gets a risk assessment of 4. Okay, and any current systemic infection, a score of 1, immobility, dehydration, a score of 1. And then you put the final score, and then you put a risk assessment. Now, once you put a final score, what do you do, right? So this is where I'm going to explain, basing upon the score, how, when, what do you start. So the risk assessment for venous thromboembolism, if the total score is more than 4 antenatally, you consider thromboprophylaxis from the first trimester itself. If the score is more than 3 antenatally, consider the thromboprophylaxis from 28 weeks. And if the score is more than equal to 2 postnatally, consider thromboprophylaxis for at least 10 days. Okay, importantly to remember is score of 4 first trimester, score of 3 from 28 weeks onwards, and score of more than equal to 2. You don't need to start this thromboprophylaxis with low molecular weight heparin in the antenatal period, but it should be considered in the postnatal period for at least 10 days. And if the lady is admitted to the hospital antenatally, consider the thromboprophylaxis. If prolonged admission for more than 3 days or readmission within the puerperal period, then also consider the thromboprophylaxis. And for patients with an identified bleeding risk, it is again the risk versus balance the risk of bleeding and thrombosis, risk versus benefit, whether the bleeding is going to pose a more danger or the thrombosis is going to pose a more danger. So basing upon that, you need to stratify, you need to reassess, and then continue with the thromboprophylaxis. And then it should be discussed in consultation with a hematologist or a high risk obstetrician who's been facing these cases, and who have this expertise in that particular field. You discuss, and then you reassess and recategorize. Okay. uh, So here I have put this table. Sorry, just a minute. So here we have, it's again a repetition of the same, wherein we're going to have a repetition of this, wherein, so when do you start the low molecular weight heparin? I just wanted you to continue this, right? The same thing, wherein you give a standard prophylaxis, and what is the prophylaxis that needs to be given is basing upon the weight of the patient, the enoxaparin, that is a low molecular weight heparin, 50 to 90 kg, you give 40 milligrams daily, and 91 to 130, you give 60 milligrams daily. When obese, 131 to 170 kg, 80 milligram daily. More than 171, you give 0.5 mg per kg body weight. Okay. So now we have come with the booking visit, ongoing pregnancy risks. Now the lady has set into labor, Now, admission criteria. So the risk assessment doesn't stop during pregnancy or at the booking visit itself. So we have reassigned, reassessed, looked for any emerging risk factors at the admission. Now, a lady comes, so she's not in labor. Not only the admission criteria doesn't mean that the lady is in labor only. We have to admit. There are certain other criteria wherein they need admission, like development of preeclampsia or high blood pressures. So any high blood pressure more than equal to 140 by 90 millimeter of mercury, decreased fetal movements, history of premature rupture of membranes, any history of bleeding during the pregnancy. If it is a high risk pregnancy, then as per your plan, when to admit, observation, antenatal steroid cover, and then how to go about with the pregnancy, what is the plan, mode of delivery, and is she in labor, right? This is the admission criteria that you put forward. Then admission risk assessment, what are all the things? So you have done the admission as per the admission criteria. Now how do you go with the ongoing risk assessment? So what are the maternal vitals? How is the CTG? If she's in labor, what is the Bishop score? What is your plan basing upon the Bishop score? Are you planning to accelerate, or she's a good Bishop scale, she's going to progress spontaneously, you're just going to observe her? Then what is the station and adequacy of the pelvis? Is your setup adequate enough to take in this particular case? Does it need an early referral? So this is a very, very important aspect, because in the last minute, and when you have assessed all these risks and they're like, oh, I don't have a blood bank facility, or this particular blood is not available with us, and at that point of time I'm going to refer the patient now. So following the admission criteria, look for all these admission risk assessment criteria, and basing upon that, plan for an early referral if you feel your particular setup is not up to it. Then, once you have done this, you do the documentation of the checklist. The gestosis scoring, the VTE scoring, the GDM risk, the admission CTG, and what is the plan for the surveillance, induction, and whether the consultant has been notified about it or not. Okay, now since we have made interpretations for tool risk assessment, so we have developed CTG interpretation also. This is as per the FIGO guidelines. The FIGO has given in 2015 a recent, interpretation of the CTG. And here also, like the traffic signal, you have a green, red and orange, wherein here you have the checklist, the first CTG that you have taken at admission, the patient's ID, the gestational age, what was this indication for CTG? Yes, we are doing CTG at admission CTG for all women nowadays, irrespective of the risk. But the RCOG, the ACOG, they follow certain strict guidelines wherein they don't do it for every low risk case. But for our medico legal issues also, it's always better to have a CTG at admission. And then you do write the parity, the obstetric history. Now, most important things to document when you're interpreting a CTG also are, what is the maternal position, whether she's in the left lateral or semi-recumbent or in any other position. Now you have ambulatory wireless CTGs as well. So what is the position when the CTG has been recorded? Then whether, I mean, if labor, any oxytocin infusion or not, if she's on infusion, what is the titration, how are you giving that rate of oxytocin infusion? Then any presence of IV fluids, what is the fetal presentation, what is the light, and the duration of recording. You've done it for 10 minutes, you've done it, I mean, as a standard we say 20 minutes, but how long have you taken this particular duration? And yeah, most of us, we keep the paper scale at 1 minute rate, but some of them have 2 centimeter per minute also. We generally put it as 1 minute, because when you see, the biomedical department has set it, or some person has changed the paper scale, and then you see a lot of variation when the paper scale is at 1 centimeter per minute and when it's at 3 centimeter per minute. And then basing, the 5 things that you check when you're interpreting a CTG. What is the baseline heart rate? What is the baseline variability? Presence of accelerations, presence of decelerations, any suspected patterns, like a late deceleration, I mean, like a shouldering, W-shaped, biphasic, triphasic. So these are the things, or any sinusoidal pattern. Okay. So as per this, you do the FIGO classification, whether it is a normal baseline, a tachycardia or a bradycardia, whether the baseline variability is normal, reactive, there is a reduced or absent, or there is increased baseline variability, then presence or absence of accelerations, then decelerations. Now, once you document the decelerations, what is the frequency of this deceleration and what is the duration of this deceleration? Because basing upon that, you have a prolonged deceleration and you have to act quickly and immediately in that particular case. See, you're prioritizing your case with the admission CTG, whether this goes to the labor ward, whether this goes to the antenatal ward, whether this goes to the ICU, basing whether it directly been shifted to the OT. So as you assess, an admission CTG is also very, very important. And contractions, like how frequently the contractions, what is the frequency, what is the regularity, what is the intensity. Yes, the recent WHO labor care guide does not put any thing about the intensity, it is only the frequency of the contractions. Okay, and finally, what is the action taken? Okay, routine surveillance, or this as an active labor, or the CTG is abnormal, non-reactive. I mean, now we don't have the non-reactive, we have the reactive, suspicious, or pathological. So basing upon that, you decide the mode of delivery. So now this risk assessment has become from an individual judgment to a system-based care. So in current modern obstetrics has shifted from, I think she's a high risk case, to it meets the objective risk criteria and she needs escalation, because this improves the patient safety, it reduces variability in the care, because you think something, the other person thinks something. But when you're following the standard risk assessment tools, and there is a standard guidelines have been given that when the scoring is this is what you need to do, or you need to reassess and you have to replan it, reschedule it, and it strengthens the team communication, and most importantly, save lives. So where do mishaps happen? That is most of the time during communication, right? During the handover times. So this risk assessment tools are a very good communicative tools actually. So what risk stratification is not, it is not labeling a patient as a high risk without any criteria, and it is not a one-time exercise at booking, and no independent you can rely on any single investigation. It is a continuous process. It is a amalgamation of the history, about the maternal history, past medical histories, surgical histories, the family history. Her environmental and lifestyle factors also are very, very important. So you have to remember that risk assessment is a dynamic, repeatable, and a auditable process. So we've taken these references from these particular guidelines, like you have this WHO antenatal care guidelines. There are this, you don't need to actually, type them and make them. There are ready printable risk assessment tools which are available in the same, the red, amber, orange, the yellow, green, white, that way also they have been given. Then the VD risk, this is actually what I felt after going through all the literature, is the RCOG Green Top guideline, that is guideline 37A. And coming to the gestosis scoring, this is given by our FOGSI GCPR hypertensive disorders of pregnancy gestosis scoring, and even the FIGO initiative on preeclampsia also gives very good risk assessment tool. I mean, these are all uniform standard guidelines. And this gestational diabetes, again from the FOGSI and the DIPSI guidelines. And small for gestational age, though the RCOG and the ACOG have given, the Fetal Medicine Foundation has given the first trimester screening and the prediction of preeclampsia, as well as the SGA scoring also has been given very nicely in that. So what I would like to say is, if there is any deterioration of the patient, has it been documented in your case sheet, right? Medico legally now, once you have done this risk assessment, so whoever sees it, or even the attendants of the mother also understand, yes, this risk assessment has been done at the first visit itself, and these have been close surveillance has been done. We are aware of these particular risks that can be associated. We have been told about the outcomes, and because of this close surveillance, the adverse maternal and fetal outcomes have been prevented, right? So risk assessment tool is a very, very important skill, knowledge based action that all of us, I won't say that it is only the postgraduates, but once your foundation starts basically from this risk assessment stratification, right from your postgraduate days, it is going to be there within you until the end of your practice. You're always going to, your mind is always going to know, and you're going to have a proper documentation, because nothing which is documented If it is not documented means it is not done. In spite of you having doing this, if it is not documented, it is not done. Okay, so since we've gone through all these algorithms, the risk assessment tools till now, let's just put few questions as per each thing. So let us see these questions. Okay. So I'm just giving you a small case scenario. This is basing upon the antenatal OPD preeclampsia risk screening. Right now, you have a 28-year-old primigravida who is of 10 weeks of gestation. She has a BMI of 32. The mother had a history of preeclampsia, and the mean arterial pressure at booking is 92. Okay, she does not have any past medical illness. Right now, what is her gestosis risk category? See, follow this age of 28-year-old, right? So that comes as a normal, a primigravida, BMI of 32, mother had a history of preeclampsia, the map at booking is 92 millimeters of mercury. So what is the risk? Definitely it is moderate risk because her BMI, a family history of 1, the map is 1, and minor risks to moderate more than 3, we have a high surveillance and aspirin is indicated. Coming to the aspirin prophylaxis, which of the following women will benefit most from low dose aspirin prophylaxis? Is it a multipara of age 24, a BMI of 22, a primigravida with twin pregnancy, a previous cesarean section with normal blood pressure, a lady with a hemoglobin of 9 gram per deciliter at booking? So, who will benefit with low dose aspirin more? So, of all these risk factors present here, it would be a primigravida with twin pregnancy, because we have seen one is a primigravida that gets a score of 1, and any multiple pregnancies we have given a score of 2. So, multiple pregnancy is a risk factor for preeclampsia. Then, coming to the VTE prophylaxis or VTE risk assessment. 36-year-old women, so remember here age more than 35, BMI of 38, delivered by emergency cesarean section after prolonged labor. See, here you see a 36-year-old lady, a BMI of 38. So these are all risk factors, and an emergency CS, what we told, a normal CS or an elective CS, or it is comes as score of 1, but an emergency CS of more than, in labor. So she had preeclampsia and received IV antibiotics for chorioamnionitis. So this becomes, she has so many risks, right? So we would go with the answer of, along with that, low molecular weight heparin for 10 days postpartum, because she's had multiple intermediate risk factors, right? These are all the intermediate risk factors. Emergency CS, BMI of more than 38, has preeclampsia, then there is a sepsis picture over here, and her age is also more than 35, right? So all this comes as multiple intermediate risk factors. In such scenarios, we have to give the low molecular weight heparin prophylaxis for 10 days postpartum. Now, what is the most commonly missed period for VTE prophylaxis? What do you think? First trimester, a second trimester, an intrapartum, or a postpartum period? Now, sometimes we do assessments, we don't do assessment, but the first trimester missing, that won't make a major difference. But most commonly, women do have this risk factor which is missed is at the postpartum period. Coming to the GDM risk stratification. Okay, a woman with previous GDM presents at 8 weeks. Her fasting glucose is normal. Okay, currently her fasting glucose is normal. Her HbA1c might also be normal. So, how do you screen this particular lady? So, should no further testing is required, or a repeat GTT only at 24 to 28 weeks, because now her fasting glucose has been normal, right? Or you do a OGTT at booking and repeat it at 24 to 28 weeks, or you just go by only HbA1c. Right now, I just wanted to comment upon this HbA1c. What I have seen is most of the times when you see in between the first trimester testing of HbA1c is fine, but second and third trimesters the HbA1c will not going to make a major difference, because when you see the HbA1c is normal somewhere 5.6 or less than 6, the fasting postprandial are also within the normal range, but you see polyhydramnias, you see macrosomias, and in those cases, what I have been telling before, as per the DIPSI guidelines, is hyperglycemia of pregnancy. Pre-post meal high blood sugars can lead to the adverse outcomes, typically like that of the GDM. Okay, so in this particular case, we do the OGTT at booking and repeat at 24 to 28 weeks if this is normal at the first booking visit. Okay, so a previous GDM always warrants a booking OGTT followed by a repeat OGTT at 24 to 28 weeks of gestation. Now coming to the labor room admission decisions. So a booked low risk woman who presents in labor, at that point of time her blood pressure has been 142 by 94. So what is the best check? So you ignore it because the antenatal period has been low risk. You recheck after delivery, or you reclassify the risk and evaluate for hypertensive disorders of pregnancy, or now the woman is in labor because of the pressures, it's increasing, so you right away start with an antihypertensive immediately. So here the best answer would be reclassify the risk and evaluate for hypertensive disorders of pregnancy. Okay. Now, coming to the last question. So, the fetal growth restriction risk assessment. Now, which woman definitely needs a serial growth scan with the Doppler? Is it a primigravida with a BMI of more than 22, a chronic hypertensive on medication, hemoglobin of 9.5 gram per deciliter only, or age 22 years? Now, all these do not come in the screening or risk assessment. I mean, they don't come as any risk factors, they come as low risk. So, here the high risk would be a chronic hypertension on medication who will require serial growth scans with Doppler. Okay, so with this, I think this is the end of the session of this risk assessments. Actually, each and every topic is again a big topic for discussion, like the hypertensive disorders of pregnancy, the gestational diabetes mellitus, the SGA, the VT, what dose of thromboprophylaxis. But here, what I wanted to highlight today is about the risk assessment strategies that we're going to do at the first booking visit and the ongoing assessment during every trimester or during any clinical indication or emerging risk which happens. So risk assessment has to be a dynamic event, a foundation for all the postgraduates, and for us to remember throughout our entire practice to give safe maternal and fetal outcomes. So thank you for your patient hearing. Any doubts, you can actually put it in the comment box. So as I have mentioned the previous, the references that I